Hi, good morning. Richard Robbins, therapeutic fellow at Baylor College of Medicine, making an educational video about how to minimize fluoro exposure. And so when we think about fluoro exposure in general, we're following the acronym ALARA, which is ALARA, as low as reasonably achievable. And what the pillars of that principle are: time, distance, and shielding as ways to minimize fluoro exposure. The main factor that I'll begin with, though, is about the beam. So the X-ray beam itself, the different factors that we can implement to minimize its exposure are first and foremost using a pulsed image. So it's not a constant stream, it's a pulsed X-ray beam, and you want that pulse rate to be as low as possible. When we talk about the beam itself, we're going to collimate the image, and so we're going to narrow in the field to as small a window as we can use and operate within. Another way we're going to minimize the exposure is by knowing the anatomical location and setting up our fluoro appropriately so that we can avoid panning before we get to the correct anatomical spot. The beam itself, we're going to want to minimize any magnification that we're using as much as possible. And if we need to mag an image for a certain maneuver, then once we've completed that, we want to then unmag and zoom back out. When we are going forward and making maneuvers where we're using our fluoro, we're going to use a last image hold feature, which is going to keep the last fluoro image on screen so that we know the location and we don't need to continually repeat fluoro. We are going to minimize the use of hard image as well, capturing hard image if we need some for documentation, then that is certainly okay. We want to minimize that feature, which is going to be a higher fluoro dose. The other things we can think about within the room itself are endoscopy screen, fluoroscopy screen could be together physically, and that's sort of an ergonomic principle that will help minimize our need to rotate our head and body of the endoscopist and the rest of the team. And the table itself can have lead drapes. We'll point to more specifically in a moment. That's going to decrease scatter of the X-ray. The room can also have a warning light outside the room that allows other healthcare providers to know that there's live fluoro being done inside the room. The fluoro tables usually have an audible alarm. By convention, we do 5 minutes audible alarm of lapsed fluoro time, just to let you know that you're using a high amount for that procedure. Some people advocate for having a fluoro tech turn on and off your fluoro, and if you're going to do that, then you're going to be using closed loop communication with your fluoro tech, which may also help decrease fluoro time. For the fluoro machine itself, here are a couple of the controls that we'll go through. First is the pulse, and so you can see from right to left, this is increasing your pulse frequency. So if you were on this setting here, your pulse frequency is decreased and you're minimizing fluoro exposure. Here are the buttons for your alarm, which will go off for a certain amount of fluoro time elapsed. Here we have our series of magnification, and in descending order, this is going from less to more magnification. You obviously want this as minimal as possible. Here's our four-way control for collimation, so you're going vertical and in horizontal direction to minimize and focus in on the anatomical area of interest for the procedure. Below, we have lead drapes, which again, patient will be inside of the drapes, but this is going to minimize scatter and decrease absorption to the surrounding healthcare professionals. When we think about the ERCP procedure, before we commit to doing the procedure, we want to make sure that we have therapeutic intent. And diagnostics really need to be done with either EUS, MRCP, a different testing modality, and reserve ERCP procedure for a therapeutic intervention. And in regards to distance, we want the rest of the healthcare professional team who's assisting with the procedure, being the nurse, tech, potentially a fluoro tech, to be as far away as possible, but still to be able to help get the procedure completed safely and effectively. We do know that for every meter a provider is further away from the fluoro table, that fluoro exposure is going to go down exponentially. In regards to shielding, a interventional room in general should be lined with lead, the walls, and most fluoro rooms will have a separate either guard wall that maybe has a window through where providers can sit on the opposite side to watch, appreciate the procedure without having to be covered and correctly shielded with lead, because that wall and the glass plane are each lead lined as well. Some fluoro rooms will be designed with mobile shields that can be moved around and can help prevent scatter by being placed in between the patient and providers. And every provider in the room should be appropriately draped with protective lead equipment. And the main types of lead, what's most advocated for would be the two-piece, and that's going to be a wraparound skirt as well as the apron. The two-piece types of lead outfit versus the one-piece, the advantage is that these are going to wrap around 360, and so if the provider is rotating the body, turning around depending on screens or positioning, they will still be adequately protected from any scatter, minimizing exposure. We also want a thyroid shield for every member in the room, and the lead needs to be hung vertically for storage, and that's going to minimize any cracks in the lead, minimize defects of the lead, and maximize its protection. We also have lead-lined clear lenses on glasses that can be used and minimize exposure into the eyes.